Thank you for joining this webinar today on CCO 2.0, which is the process for outlining the future of coordinated care in Oregon. My name is Jeremy Vandehey. I'm the Acting Director for Health Policy and Analytics with the Oregon Health Authority, and I am joined with Stephanie Jerem, also with the Health Policy and Analytics Division with OHA. Just a quick note on language and accessibility. Everyone has a right to know about and use OHA programs and services, and OHA provides free help to do so. If you need help or have questions, please contact Stephanie Jerem at 971-273-6844 or email her at cco2.0@state.or.us. Today we're going to provide a quick overview of the CCO 2.0 process, starting with a brief history of health system transformation in Oregon and background on what coordinated care organizations are. We're going to talk a little bit about some of the successes and opportunities from the first 6 years of CCOs, and then talk about the process and vision for the next phase of coordinated care in Oregon. First, coordinated care organizations started in 2012 with really the goal of achieving what we call the triple aim goals, which are improving care both in terms of quality and patient experience, improving population health, and lowering healthcare costs. It's been 6 years since we first started CCOs in Oregon, and we've learned a lot. We have a lot of data information on the progress to date, as well as opportunities. The current CCO contracts will come to an end at the end of 2019, and we're in the beginning phases of mapping out what the next 5-year contracts, which will begin in 2020, will look like, and we're calling that process CCO 2.0. So why is this important to you? Well, first, 1 in 4 Oregonians, or nearly 1 million Oregonians, now receive their health care coverage through the Oregon Health Plan, which is Oregon's version of the Medicaid program. And most of those members, or most of those patients, receive their health care through CCOs. If you're not a CCO member or a provider, you still probably should care about this, because about $14 billion of the state's biannual budget goes towards Medicaid, which is almost 20% of the state budget. And so this will be one of the largest procurements in the state in nearly a decade. So who's leading this work? The Oregon Health Authority is. It's the state agency that's responsible for Medicaid, and it's the state agency that contracts with coordinated care organizations to provide Medicaid services, as well as the Oregon Health Policy Board, which will be really setting the policy direction for the longer-term vision. The Health Policy Board is a 9-member volunteer board that's appointed by the governor, and it's the policy-making and oversight body for OHA, and much of the public engagement process that will happen throughout the year will be through the Oregon Health Policy Board. So just a little bit of history about what CCOs are and why we created them in the first place. Prior to CCOs, Oregon had a very fragmented and uncoordinated system of healthcare. We previously contracted for mental health services and physical health services and oral health services totally separately, leaving patients with having to navigate that complex system of care. That ultimately led to a higher cost, because each part of the system was only paid if they provided more and more care. And it didn't matter what the quality of the level of the care was, and there wasn't an incentive for the system to be efficient and to provide the best care for patients. We know that healthcare costs have been unsustainable, not just within Oregon, but across the country. Many countries spend between 9 and 11% of their gross domestic product on healthcare, but between 1980 and 2013, that rose to about 17-18% within the United States, which tracks with the state's budget. And when we're spending more money on healthcare, just like when families and businesses are spending more money on healthcare, that leaves less financial resources for other critical investments like housing and education. In 2011, the state was faced with a pretty significant budget challenge across the budget, including within Medicaid. Traditionally, we've balanced the Medicaid budget in tight times by either through cutting eligibility, cutting benefits, or cutting provider rates. And the challenge with all three of those is they ultimately result in less access. And when there's less access to the care that people need, they end up in the emergency room, which is the most expensive point of service and the only part of the system that has to provide coverage, and those costs are passed on to the rest of us. So we decided to pave a fourth path forward, and really looking at ways to improve the delivery of care so that it would reduce waste in the system, improve the health of the population, do that through creating local accountability, and aligning financial incentives to be able to focus on performance and outcomes. And the goal of doing all of those was that it will ultimately would lead to more fiscal sustainability. We called the new system a coordinated care model system, and rather than having the fragmented puzzle pieces that you saw earlier of the system completely separated and not working together, the idea was to bring major components of the healthcare system together through a coordinated care organization that would integrate and coordinate care by focusing on prevention, improving quality, better coordinating care, and really putting patients at the center of the system. The hope was that it would both improve outcomes for patients and ultimately reduce costs. So just a little bit more about what CCOs are. They're community-governed organizations. They are responsible for bringing the major components of the healthcare system together, and they're governed by local boards that have representation of the major parts of the health system. CCOs receive a fixed monthly payment that we call a global budget, and are responsible for providing all of the healthcare that patients need within that global budget. And within the global budget, they have the flexibility to address what patients need. And the idea is they obviously are responsible for providing healthcare, but the hope is that they could also focus more on prevention and focus more on things that will keep patients out of the doctor's office and out of the hospital in the first place. CCOs first started in 2012, and today we have 15 CCOs that cover the entire state. Most parts of the state just have one CCO, and there's a couple parts of the state that have multiple CCOs. As I mentioned, CCOs are funded through global budgets, which is this integrated budget that includes both physical, behavioral, and oral health. They have the flexibility within that budget to be able to spend money the way that the community best sees fit in order to improve quality and improve outcomes. But they're also accountable for staying within a sustainable rate of growth and staying within that budget. In 2012, the state of Oregon signed a waiver with the federal government. That was the first of its kind, where the state actually committed to reduce healthcare costs by 2 percentage points below what costs were expected to be in exchange for an upfront investment from the federal government. CCOs are also paid in part for improving quality. Transparency and quality improvement is a really critical piece of the coordinated care model. The state sets quality targets and then measures CCOs based on meeting those targets and publishes reports in a transparent way to be able to show how each CCO is doing. And if they meet their targets, then they receive some additional funding. So what do we know about the first 6 years, or what we'll call CCO 1.0? Well, we know that CCOs have actually reduced the rate of growth of costs. They're improving quality and they're improving member health. The CCO model since 2013 has grown at a rate of growth of 3.4% instead of the 5.4% that we would have expected without transformation. And that has resulted in about $2.2 billion in avoided costs over that 5-year period. And CCOs are improving quality. They've increased enrollment into primary care, which has part of the reason that we've seen some of the savings. They're reducing avoidable emergency room visits. They're improving developmental screenings for kids. And we also know that patient satisfaction and reported health of patients has also increased over the last several years. And this just shows some of those key measures that I just mentioned. So what will CCOs look like in the future? Well, that's the process that we're undertaking right now. As I mentioned, the first CCO contracts will end December 31st, 2019. We are in the beginning stages of developing really what the key policy goals will be for those next 5-year contracts. So throughout 2018 this year is that process, and it will wind up with a report from the Oregon Health Policy Board this fall. 2019 will be the formal procurement process. We're expecting that will begin in January. And then the contracts will be awarded later in the year, and those new contracts will start on 1/1/2020. Really, the idea behind CCO 2.0 is not to completely uproot and change the system. We went through that transformation in 2011 and 2012. This is really the next phase of this transformation around the triple aim and getting clear on where the areas are that we want to focus in on. Governor Brown recently wrote a letter to the Health Policy Board outlining her vision, and that includes increasing the focus on paying for value and performance instead of for volume of services, focusing upstream on things that keep people healthy and out of the doctor's office in the first place, and some of those things are outside of the traditional healthcare system. We call them the social determinants of health, which we know are increasingly have a bigger and bigger impact on health equity. Continuing to improve behavioral health and making sure that patients can get access to the addictions and mental health services that they need, and continuing to maintain a sustainable system and holding down costs. So now I'm going to turn it over to Steph to talk a little bit more detail about the CCO 2.0 process.
Great. Thanks, Jeremy. So I am going to begin by talking about the work that is being done in policy development over the next few months. There have been some work plans shared in the 4 areas that have been identified by Governor Brown at the most recent Health Policy Board meeting, and all of these are available on the Health Policy Board's website, which I'll have a link to at the end of this webinar. We spent some time at OHA identifying policy options that would be useful for exploration over the course of this year. So those policy options were identified based on things like whether or not there were existing recommendations already from a public committee or a board, whether these topics were priority issues and ideas that we've heard circulating over the past few years as we've begun to really think about where the future will lead us. We have looked at existing research and best practices in these different areas, and we've also looked at other states and systems to see how they've tackled some of these issues. Based on that and the applicability to CCO 2.0, the feasibility of having this fit within the time frame that we're looking at, the readiness of the state to tackle some of these issues, and other timelines, the list has been narrowed. And so work plans were built that allow for much more in-depth research and analysis, cross-topic and cross-agency collaboration, lots of public input, and our goal is to develop some straw model recommendations by the June Health Policy Board meeting. So I'm going to begin by walking through each of the 4 topic areas and explaining a little bit about what the topic area is, what we know about it so far and what has worked, our lessons learned, and then also what we're going to be exploring in 2018. So we're going to do that for each of the 4 topic areas. I'm going to begin with behavioral health. Oregonians who struggle with behavioral health, which are mental health challenges and addictive disorders, face barriers every day to getting the services and support that they need. The behavioral health system continues to include fragmented financing, carve-outs that prevent integration, and a siloed delivery system that really separates care. Access to specialty and general behavioral health services doesn't really meet the needs of all Oregonians in terms of being in the right place at the right time and in a culturally and linguistically specific manner. Coordination between systems such as criminal justice systems, human services, health, and education is really insufficient. And the social determinants of health, such as insufficient housing, education, employment, and transportation, often end up creating barriers to behavioral health resources. We also see that there are a lot of points about understanding that there's a national shortage of behavioral health providers, and So even though Oregon has made progress, there's much work to be done to integrate behavioral and physical health. So this lays out a little bit of a high-level understanding of what our behavioral health system looks like. And again, our behavioral health is encompassing both mental health and addictive disorders. So CCOs have service coordination agreements. These are special agreements with community mental health programs. Those are the CMHPs you see on your screen. CCOs may contract with the CMHP to provide services, or they may contract directly with other behavioral health service providers. CMHPs either then provide behavioral health services or then contract again with other providers in the community to provide the services. It can get complicated pretty quickly. Oregon's current behavioral health status is shown on this graphic. We see that data show that consumers are not currently receiving sufficient or consistent behavioral health services throughout Oregon. For example, we know that Oregon ranks 4th nationally in opioid use. We also would highlight that Oregon is ranked 14th nationally in youth suicide, and suicide is the second leading cause of death for young adults in Oregon. We have ample opportunity for improvement. So here are some things that we've learned in the first 5 years. We know that integration of the benefit doesn't equate to integration of services. Since the inception of the Affordable Care Act, there has been an increase in people receiving behavioral health services. However, what we've learned in the past 5 years is that integration doesn't result in integration of services necessarily. And while we've seen improvements in physical health outcomes, such as reduction in the number of emergency department visits, we have not seen the same reduction in emergency department visits for people with mental illness. What we need to see is behavioral health services that are truly integrated with physical and behavioral health services. So we really will need to balance the CCOs to delegate administration of behavioral health with that accountability. And then some successful CCO outcomes for physical health haven't been as successful for the behavioral health population, as I mentioned. So over the next few months, what we'll be looking at is answering some questions. Governor Brown had identified 3 specific areas within behavioral health for the Oregon Health Policy Board to focus on. That included reducing emergency department utilization, increasing access to community-based behavioral health care, and focusing on children with behavioral health needs. So looking at that, the Health Policy Board and Oregon Health Authority developed some questions that would really lead us down the path of understanding how to improve CCOs. Those questions include, how will we measure integration? How can we encourage investment in behavioral health and hold CCOs accountable for these investments? How can we ensure the system has the workforce to achieve expected outcomes? And how do we ensure that children receive comprehensive behavioral health services no matter where they live in Oregon? So you'll see those questions or similar questions on the left-hand side column. And on the right-hand side, we have the policy options that this group is going to look at, and we've really narrowed them down. So for example, for the first question, how will we measure integration? In order to know that we are successful in integrating the behavioral health system, we must identify meaningful measures. We also need the technology, including electronic health record and electronic health information technology. By investing in technology for behavioral health providers, we expect increased care coordination and support for integrated physical, behavioral, and oral health care. For the second question, how can we encourage investment in behavioral health and hold CCOs accountable for those investments? Our current behavioral health system is fragmented and siloed, as we've talked about. Addressing billing barriers between physical and behavioral health and then aligning contracts will improve access to behavioral health care for all Oregonians. The policy options on the right-hand side all get at some of those issues. For the third question, we ask, how can we ensure that the system has the workforce needed to achieve expected outcomes? So the goal here is that OHA is going to assess the current behavioral health workforce. That's work that's ongoing right now. Once this assessment is complete, we are going to develop and implement a recruitment and retention plan, which will be complete by March 31st of 2019. Meanwhile, we must ensure that we have culturally and linguistically appropriate services for all Oregonians. And so that's really what they'll be exploring within this space over the next few months. And then finally, for the fourth question, how do we ensure that children receive comprehensive behavioral health services no matter where they live in Oregon? There must be a full continuum of care across the entire lifespan. So this means prevention, early intervention, treatment, residential care, and ongoing recovery support services. And these 4 policy options will all look at understanding how we can better achieve that through CCOs in the next contracting cycle. So now I'm going to move on to the social determinants of health and equity. One of our primary goals for the next 5 years of coordinated care organizations is to increase health equity in the healthcare system. Health equity is about fairness and social justice. It means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing economic and social obstacles to health, such as poverty and discrimination. Another term for obstacles like poverty and discrimination is the social determinants of health. The social determinants of health are the social, economic, political, and environmental conditions in which people are born, grow, work, live, and age. Social determinants of health aren't fairly distributed in communities. Policies and structural factors like racism, sexism, ageism, and others mean that certain groups face more factors like poverty and other social determinants of health than others. These structural factors are also called the social determinants of equity. So now that we've learned a little bit about that, let's look at how they are all tied together. This image shows how the social determinants of equity, like racism and sexism, are connected to the social determinants of health, like poverty and employment. This graphic also shows the different social, political, and environmental conditions we mean when we say the social determinants of health. Oregon's Medicaid Advisory Committee, which is a stakeholder advisory group to OHA and the Department of Human Services, is in the process of coming up with a definition of social determinants of health and equity for Oregon CCOs. This graphic is the draft definition for your knowledge and review. So why are the social determinants of health and equity so important, and why are we looking at this? We know that healthcare is important, but the medical care we get only determines about 10% of our health overall. Social and environmental conditions, or the social determinants of health, actually make a much bigger difference in how healthy we are. In order to keep transforming the healthcare system and help Medicaid members improve their health, we need to expand the work that healthcare partners do to impact social determinants. These are things like housing, education, economic stability, food insecurity, those types of things. So what have we learned in the first 5 years? Well, when we looked at the last 5 years of CCOs, 5 to 6 years, we saw that CCOs are already starting to do work to address the social determinants of health, especially in areas related to housing and addressing trauma, including trauma during childhood. However, there's more work that we can do. When we looked at CCO financial reports, we saw that CCOs weren't reporting high investments in health-related services, which is a flexible part of a CCO's budget that can be used to provide services that might address a person's social service needs, like transportation needs or the need for healthy food. There are lots of reasons we saw those low investments, including a lack of understanding about how CCOs could use them. We saw that CCOs had partnerships with community partners that could support work related to social determinants of health and equity. Some had more and some had less, and the types of partnerships, for example, whether they had a formal contract or they just worked on a shared plan together, really varied. When we looked at healthcare access and health outcome data, we saw disparities, especially related to race and ethnicity. However, the data that we have on race and ethnicity has limitations. And when we looked at the workforce, we saw that we need to know much more about how CCOs are using certain providers like traditional health workers, which are community health workers and doulas and peer support and peer wellness specialists, as well as healthcare interpreters. Yet we know that these types of workers can make a really big difference in helping address the social determinants of health and equity. So, based on these lessons learned, we are considering the following policy questions and policy options. So first of all, how can we encourage CCO investment in social determinants of health and health equity? In other words, how do we require or otherwise encourage CCOs to spend more of these funds in these areas? And you can see on the right, there are a number of policy options here that will be explored. So, for example, things like looking at ways to promote CCO use and reporting of health-related services, whether or not there should be requirements or other ways to promote or increase spending related to social determinants of health and equity, CCO incentive metrics that might address social determinants of health and equity. Those are all examples of the policy options we'll be exploring. The second question is, how do we ensure that CCOs have a culturally and linguistically competent workforce that reflects the population they serve? And so in this category, we'll be looking at how community advisory councils are currently utilized and what the connections and representation look like both on community advisory councils and with CCO governance boards overall. The third question is, how do we better ensure provider cultural competency, language accessibility, a diversified workforce, and access to critical services across the state within a CCO and its provider network that reflects the population served? So here they'll be looking at whether or not there are options for internal workforce and infrastructure requirements, strengthening requirements for traditional health worker contracting and utilization, and exploring strengthening of telehealth reimbursement requirements. And finally, the last question is to understand how we can better improve our understanding and get better data around social determinants of health and equity. So now we're going to move on to the third category of value-based payments. So most entities that pay for healthcare, such as health insurance companies, paid for healthcare using a model that's called fee-for-service, which pays for each healthcare service, visit, or test that a patient receives. The goal of paying for performance or value-based payments is to move away from those payments that are based solely on quantity of services delivered towards payments that reward providers for improving the quality of their care and for better health outcomes for the patients that they see. In other words, value-based payment is not just about moving away from fee-for-service. It also must include that link to improved quality of care. The Oregon Health Authority currently pays CCOs using a value-based payment model. Specifically, OHA pays CCOs a set amount of money, which is called the global budget, that gives CCOs flexibility to ensure their members receive the care they need. CCOs then also receive financial rewards for providing high-quality health care to their members. These payments are tied to CCOs' performance on 17 different incentive metrics. So what did we learn about value-based payment in the first 5 years? Value-based payments in Oregon's Medicaid program can exist at two different levels of Oregon's Medicaid program. First are payments from OHA to the CCOs. This is the payment we referred to as a global budget, as I just explained. The second are payments between CCOs and their contracted healthcare providers. Through information collected from CCOs over the first 5 years, we learned that all CCOs have non-fee-for-service arrangements with their providers. However, there is less experience linking these payments to quality of care, which would then make them actual value-based payments. Unique characteristics within CCOs, including differences in geography, the number of members, and the provider market power, means a single one value-based payment model would not work for all CCOs. The goal of CCO 2.0 is to increase the degree to which value-based payments are used between CCOs and their providers, encouraging a healthcare delivery system that rewards quality and better health outcomes. We're also investigating ways to enhance the OHA to CCO value-based payment model. So the goal of CCO 2.0 in this area is to increase the degree to which value-based payments are used between CCOs and their providers. This would build a healthcare delivery system that rewards quality and better health outcomes. We're also investigating ways to enhance the OHA to CCO value-based payment model. Specific questions that are being considered as part of CCO 2.0 include, should the percentage of CCO global budgets tied to performance and quality increase? So this is looking at OHA payments to CCOs. For the next questions I mentioned, note that OHA is in the process of developing a value-based payment roadmap, which is a requirement of our 1115 Medicaid waiver that will include value-based payment targets for CCOs. This roadmap will be folded into the CCO 2.0 process, just so you know. So these questions include, how can OHA encourage value-based payments between the CCOs and their providers and hold CCOs accountable? And then, should value-based payments that reduce health disparities and address the social determinants of health and foster improvements in behavioral health outcomes be incentivized for CCOs? And finally, the final question that they're looking at is, what changes to data collection are necessary in order to track progress on and improve our understanding of value-based payment utilization? So let's look at the last category of sustainable spending and cost containment. Ensuring the fiscal sustainability of the Oregon Health Plan, which is our Medicaid program, is critical to Oregon's efforts to make sure that Oregonians have access to high-quality health care services they need. The coordinated care model aims to control healthcare spending not by reducing access to healthcare services, but instead by investing in primary care, paying for value, and improving health outcomes to reduce healthcare costs in the long run. We know that cost growth is a challenge. This is a nationwide issue. The nation spent $3.3 trillion on healthcare in 2016, or more than $10,000 per person. We've reduced the growth in healthcare spending in Oregon, as you saw in the earlier slides, but we need to continue this trend with focus on containing prescription drug spending, holding CCOs financially accountable, and adjusting financial incentives to reward CCOs for improving quality over quantity. So what did we learn in the first 5 years related to costs and spending? Well, Oregon's sustainable spending targets provide an important tool to help the state and its CCO partners control annual spending growth. We also know that CCO flexibility within the constraints from global budget spending limits provide the incentives for CCOs and providers to be innovative in care delivery, while information sharing and technical assistance from the state then helps spread effective CCO practices and reduce costs while maintaining robust access to healthcare services for members. Incentive payments based on CCO performance help motivate CCOs and their provider partners to achieve performance goals that indicate better quality care and patient health outcomes. An increased investment in primary care services help improve care for patients while reducing costs to the healthcare system, as indicated by return on investment calculations for Oregon's patient-centered primary care homes. So these are the questions and policy options that the cost team will really be looking at. So the questions include, is 3.4% still the right target for the entirety of the CCO contract period? What cost drivers threaten continued achievement of the sustainable growth of 3.4% in future years? What cost drivers warrant additional analysis and focus to help OHA and CCO partners continue to meet legislative and waiver-driven growth targets? And then what strategies could OHA pursue to increase CCO financial accountability while preserving adequate CCO flexibility to operate within global budget? So you can see here there's a number of policy options, especially towards the bottom, that will need to be explored and investigated over the next few months. So how can you get involved in this process? We are dividing this work into 3 major phases. Phase 1 will focus on the development of draft policy recommendations. This is a phase where we will be exploring and investigating policy options to better understand if they work for Oregon and for CCOs. This is also the time for you to bring forward any ideas you have about how to improve CCOs in the future. We want to make sure that we have plenty of time to discuss and learn along the way. Some of the opportunities for public input during this first phase include taking our public survey, attending one of the committee meetings that are already planned, participating in a public forum, which we will have a date that will still be announced, emailing us your ideas, attending an Oregon Health Policy Board meeting and providing public testimony, or inviting OHA or OHPB to come speak at your event. Phase 2 will focus on reviewing and refining the policy ideas and recommendations. We're expecting that at the June Oregon Health Policy Board meeting, we'll have a presentation that will show an early first draft or a straw model of the recommendations that have been explored throughout that first phase. We'll invite public input during the entire second phase by taking another survey, attending a roadshow event, which is currently going to be scheduled for the last 2 weeks of June and will take us around the state, continuing to email us feedback, and attending an Oregon Health Policy Board meeting and providing public testimony. Phase 3 will focus on operationalizing and finalizing the recommendations. This stage will likely incorporate more than just CCO recommendations, and will also provide context as to how OHA will implement any of the anticipated changes. This slide provides a glimpse into the public meeting schedule that you can follow online at our website. On the right-hand side, you see all of the different public committee and organization meetings that we are currently planning on attending to either discuss policy options or to bring forward some ideas. Other ways, just to highlight again, for public input throughout the process is an online survey that we have open from March 15th today to April 15th. You can access that on the OHPB website. We have all of these existing committee meetings. This will continue to be added to. We have a public forum that will occur in April. The date is still to be determined, and we'll announce that when we know. There will be targeted meetings and surveys for specific topic areas as needed. So, for example, we're expecting that we'll need to bring forward the cost issues and questions to specific targeted meeting, maybe not an existing committee. And so in that case, we'll be sure to give lots of public notice about those meetings. And there may be surveys that are targeted for specific groups, such as providers. There will be a summer roadshow, and we're also inviting extended public comment at Oregon Health Policy Board meetings. So please know that that's another opportunity to bring forward any ideas that you have. If you're interested in specific policy options, this slide will explain how to track those. So each topic area of the 4 topic areas that I mentioned, behavioral health, value-based payment, cost containment, and social determinants of health and equity, is looking at specific policy options. In the example that I have here, the social determinants of health and equity topic area is currently exploring 9 policy options. We built this table into each of the work plans that are available on the website so that you can see when and where each of the policy options will be discussed. For example, if you wanted to hear the discussion on policy option number 5, you would realize that you don't need to attend the May 2nd healthcare workforce meeting, as it will not be discussed at that meeting. All of these work plans and public input is available on the OHPB website. The online survey will be open from March 15th to April 15th for the general public. Our goal is to include this feedback during the policy development phase from anyone interested without requiring your attendance at some of these meetings. We really want to get as much of our input in and new ideas early in the process so that we have the time to engage and start to understand what those policy options and ideas would look like. The format for the survey is that it will be mostly multiple choice. There will be 3 to 5 general questions on CCOs, as well as some questions for each topic area. And then we'll have an open-ended opportunity for general feedback, suggestions, and ideas. So I've attached here a couple of links. You can also just Google the Oregon Health Policy Board and get to the CCO 2.0 webpage. That webpage also includes a list of the public meeting schedule, which will be updated. I ask that you take our survey, which is also on that website. And if you have any other questions, please feel free to email us at any point in time at cco2.0@state.or.us. Thank you.